Good evening, PC sir. So you are on mute.
Good
Yeah.
evening. Hey.
Good evening, sir. So we'll start at 8 o'clock.
Okay, done.
I think we have all panelists and speakers. Everyone almost has already joined today. Dr. Badani is also there. Good evening, sir. And Bijoya is also there. Bijoya, your audio is still not there.
Not there. Yes, good evening, everyone. Am I audible?
Yes, sir.
Okay. So I think not bad. I am reasonably on time.
Absolutely, sir. Before time.
Yeah. I'm not sure how the Google Meet will respond. That's why.
So I think the biggest challenge is logging in via a Gmail ID.
Yeah, I think it somehow was comfortable. I had already done that, so it was on the thing before I this. But okay, looks good, I believe. So we'll be starting at 8, na? We have another 5,
Yes,
8
sir.
minutes.
Another
Correct?
5, 8 minutes. Yes, sir.
Okay, so I'll just keep the video off for a couple of minutes and join
Yes.
back. And I'll be keeping it on.
Right, sir.
Good evening, PC sir. I think I'm audible now.
Yes.
Hello, Nancy. Can you hear me, Nancy?
Hi, Dr. Cheng. Yes, can hear you.
Good. Thank you.
I know it's pretty late for you.
Yeah, it's okay. No worry. Yeah. Thank you.
I think I'll send a reminder to Dr. Hind.
KFC మొత్తం కూడా KFC మొత్తం
A very good evening, good morning, good afternoon, everyone from wherever you've joined. It's a pleasure to have you all here, and we welcome you today on our webinar as part of the webinar series. On the webinar, today's webinar being Salt, the Silent Threat, and Reducing Sodium for a Healthier Heart. Today, we commemorate the World Heart Day. And it's an absolute pleasure that as we celebrate World Heart Day, we are reminding ourselves of the importance of cardiovascular diseases and the role that salt plays. We will talk about the importance of salt, but we will also try and figure out if there are strategies or what are the strategies that we can adopt, what are the proactive actions that we can take to overcome the burden of high salt intake, which in itself has become a public health challenge. Today, we have with us national and international experts who have been working in this field, I think, relentlessly for years. And hopefully, we look forward to coming up with solutions and enlightening everyone here about what the different perspectives from different parts of the world are. Just give me a second to share the screen. Before we begin, I'd like to invite our past president of IPN India and the director, Dr. PC Vijay Kumar. I think a visionary and a guiding force for IPN India. We are here because of the way you've guided us to be. He is the founder president for the South Asia Association for Parenteral and Enteral Nutrition as well, and has over 30 years of expertise in anesthesia, critical care, pain management, clinical nutrition, and bronchoscopy, as well as a very strong advocate of nutrition. Sir, it's an honor to have you here to inaugurate our webinar today and to talk to us about, what your thoughts are on this. Over to you, PC sir. Sir, you are on mute.
Thank you very much, Mansi, for inviting me in the last minute to give an open note for this particular webinar. Respected Dr. Norman, who is going to be the keynote speaker for this webinar, we are very happy to have you in this webinar. On behalf of IAPN India, it's my privilege to take up this webinar to the Indian population. Not only in India, I think there are many other international delegates also going to participate in this webinar. Since this morning, India is very busy in celebrating World Heart Day. Even today in our own hospital, from the morning, started with the walkathon, and then we had a meetings, and we had a cake cuts and everything. So this is how the India is celebrating the World Heart Day today. And in the entire day of meeting, we talked about nutrition, and we talked about exercise, and we talked about the lifestyle modifications and everything. But if you look into this webinar, it is a unique webinar where we are going to talk about the salt. Interestingly, the creatures in this world originated from the sea water. If you take our plasma, the sodium and the potassium and all the minerals are equal to that, or more or less similar to that of the sea water. Though we all come from that particular sea water, if it goes excess at this particular point of time when we've grown up and evolution is gone to a greater extent, the very same salt can do harmful thing to us. And I like to appreciate the people who have coined this word, salt satyagraha, for this entire movement. I don't know, India is very familiar with the word satyagraha. I just to give an introduction to the international delegates here about the salt satyagraha. In our independence struggle, in the year of 1934, Mahatma Gandhi took a Dandi Yatra, and Dandi Yatra is against the tax imposed by the British people on the salt. And that movement, very famously called as a civil disobedience movement. But this time, when we are against this salt taxing on our health, this salt taxing more on our health hazards. And we are in this Satyagraha movement, and this is not civil disobedience movement, where we want actually the civils to have a obedience in omitting that salt. So this is a comparison, and I like to appreciate the people who have coined this word Satyagraha for this movement, and it is very apt. And as I put up in the flyers, we are in the salt Satyagraha. So here we have an eminent panel and a very good speaker. He is going to talk much about the salt restriction and other things. Being a critical care physician, when you're talking about the preventive cardiology and avoiding the salt in the intake, when my patient get admitted critically ill in the hospitals, I am actually worried about the saline infusions which we are giving to the patients. The normal saline, which was claimed to be a normal, it is not normal for the critical care physician. It is an abnormal saline. When we are transfusing normal saline to our patient, more than 2 bottles a day, then it's going to be the 18 grams of salt which we are going to infuse on our patients. And the salt Satyagraha include our critically ill patients also, and take up this message to the critical care physicians that the normal saline is also a form of salt, and that salt should not be given to the critically ill patients. With this short introduction, I'm very eager to listen to our keynote speaker, Dr. Norman, and with the panelists, I think definitely we are going to have a fruitful webinar on the salt and the salt intake prevention, which is going to cause a good, healthy individuals in this world. Over to you, Mansi.
Thank you, sir. And I think there's no one better who could give that introduction to us and set forth our session today. So the credit of coining the word salt satyagraha goes to Microlabs, who's steered this whole campaign of developing a salt calculator. But before I start, I think it becomes imperative that as IPN hosts this event, we request all of you to take up the membership. You can scan the QR code to access the membership form that's there. It'll be a pleasure to have you on board. I would be moderating the session, and it's an absolute pleasure and an honor to introduce Dr. Norman Campbell. I think for those of us who worked in hypertension and have tried to work in the field of salt and hypertension, there's no way that we could not have heard his name or not read his research papers or been inspired by him. I think it's fair to say that he's probably the father of salt when it comes to hypertension, with the the path-breaking research and concepts that he's had. So yes, it's an honor, sir, to have you here. I've tried to collate whatever information I could get, but I know this slide probably does not justify your contribution to the field that we are talking today. As the past president of Blood Pressure Canada and the Canadian Hypertension Society, I know you've been part of developing the salt calculator for Canada as well. And he's part of the World Hypertension League, who has very kindly accepted to become a collaborator and support us in this campaign for salt, developing the salt calculator. What we'll do is I'll share the recordings so that we do not have any technical glitches, and then Dr. Norman is here for us to be a part of the panel discussion as well. So just give me a while to figure out the recording part. Please do let me know if the slides are visible. I mean, the screen is visible.
Yes, it is visible.
And audio.
Can you please increase the volume? Maybe the volume is a little less.
On less sodium or salt.
Better?
Diet. I was asked to talk about some of the adverse effects of high dietary sodium on human health.
I think we need to increase the volume a little more, Dr. Marco.
All right. I think we did figure out the equalizer last time.
Most recent globally, high blood pressure, hypertension. This and you can see the diet toxin. This next slide. Indeed, you see it's somewhat different.
I'm going the laptop section and then put all that pointers about.
Starting from fourth to third rest. Next line here.
Mansi ma'am, go in the laptop section first.
Swati, we are already in the laptop section.
Yeah, in the laptop
We are
section.
already doing that.
Yes, in the laptop section, you just to put it.
I think we
Yes. All top.
Yeah.
All top.
no, then it gets customized.
Acknowledging that India has a very large proportion of the world's population. Now, as we move to dietary risks for death, you can see that high dietary sodium is the dominant risk for premature death. This dashed line here represents 2 million premature deaths. One can see the role of trans fats and sugary beverages, a major source of sugar in the diet, being substantially lower. In the next slide, India is quite a bit different, and this really represents that India is still going through nutrition transition. Hence, I've just displayed the data somewhat differently. 1990 rankings and 2021 rankings. And what you can see is that high dietary sodium has moved from 7th place up to 5th rank. And this will likely continue to increase as India transits from unprocessed foods to an ultra-processed food diet. Now, I should indicate that there's a substantial flaw in the disease study relating to high dietary sodium. They had a serious methodologic issue where they included data which had false results that I will talk about a little bit later in my talk. Now we're moving through increasing dietary sodium and in particular cardiovascular risks, which are the main adverse outcome from high dietary sodium. Here we're looking at the Yanomami indigenous tribe from South America. They have an average sodium intake of about 100 milligrams per day. They are hunter-gatherers, highly physically active in a very hot climate, and they show no features of sodium deficiency. As we move to the next level, between 100 and 300 milligrams per day, long-term physiologic studies in small numbers of healthy volunteers show no adverse physiologic effects or sodium deficiency at this level of intake. Now, the only report that I'm aware of that examined adequate intake was the Australian and New Zealand government, which suggested adequate intake, i.e. no adverse health effects, between 500 and about 1,000 milligrams per day in healthy individuals. This does not account for disease, and certainly people with diarrheal and other diseases where they become volume deplete may require substantially higher amounts of sodium. Paleolithic diets are those that we all evolved on. They were between 500 and 750 milligrams per day, and no evidence of sodium deficiency. In the lower range, these are vegetarian diets, and in the higher range, these represent higher sodium, which comes from meat products. Once we're at 800 milligrams per day, we're starting to get into clinical research. This is the lower level where there were randomized controlled trials, either decreasing or increasing sodium and watching the effect on blood pressure. They showed that there's approximately linear increases in blood pressure, and sodium increases about 800 milligrams per day. Once we get to observational epidemiologic studies, we can see that the hypertension prevalence increases in populations above 1,000 milligrams per day. Below 1,000 milligrams per day, hypertension is very rare, and blood pressure does not increase with age. Notably, these are hunter-gatherer populations at 1,000 below milligrams per day, and are incredibly rare today. As we start to get into levels of sodium consumption that we see in our populations today, with the highest quality cohort study, which is a meta-analysis of studies that define the sodium intake by multiple carefully collected 24-hour urines. This is represented by this line here. What it shows is a linear decrease of 17% cardiovascular disease per 1,000 milligram decrease in dietary sodium. The linearity was demonstrated between about 1,000 milligrams per day and 6,000 milligrams per day. The highest quality data that we have is a meta-analysis of randomized controlled trials, post-trial follow-up, which examined an weighted average of dietary sodium from about 650 milligrams per day to about 2,700 milligrams per day, and showed a reduction in cardiovascular disease of about a quarter, 26%, and mortality of about 15%. It demonstrated linearity of 2,300 milligrams. So, modest reduction in dietary sodium, fairly substantive reduction in cardiovascular disease and death. These high-quality research studies are in sharp contrast with low-quality research studies, which are really epitomized by the PURE study, which tried to assess a person's long-term sodium intake by a single morning spot urine sample of the Kawasaki estimating equation. And it estimated optimum intake was between 3,000 milligrams and 5,000 milligrams, with increases in disease above 5,000 milligrams and increases below 3,000 milligrams per day. So it has been reported that sodium can be highly toxic, and so acute ingestion of sodium in children has resulted in fatalities at about 5,000 milligrams per day, and in adults at about 6,800 milligrams per day and above. In children, this could be murder attempts, it could be accidental ingestions in hospital replacing sugar for sodium. In adults, it's typically when they were using sodium gavage to get people to throw up after overdoses, but also a lot of these people had other health issues, but some were just challenges by saying something like drinking this bottle of soya sauce, and resulted in fatal increases through increases in blood sodium levels. Summarize the impact of dietary sodium. It's approximately linear on blood pressure, about 800 milligrams per day. One did a rough calculation of increases in sodium above the WHO level of 2,000 milligrams per day. It would account for about 30% of hypertension. If someone were to ingest a significant amount of sodium, blood pressure would increase within hours if they were sodium sensitive. Talk about some sodium sensitivity or resistance question period. Short-term increases in intake have about half the hypertensive effect of longer-term interventions greater than 4 weeks. The impact of dietary sodium on cardiovascular disease is linear, about 2,000 milligrams per day to 2,300 milligrams per day. These trials do not establish a lower safe level of sodium intake. The data runs out at about 2,000 milligrams and 2,300 milligrams. There's no indication that sort of lower amounts is still safe, and that sodium is not causing harm below those levels. High dietary sodium has been associated with a variety of other adverse health circumstances. High dietary sodium causes widespread inflammation in the body and an increase in reactive substances. It's probable procarcinogen from gastric cancer. People with recurrent calcium urate Oxalate stones causes an increase in recurrences. It's associated with a huge spectrum of human diseases, including osteoporosis, headache, cardiac hypertrophy, renal impairment, dementia, vasculitis, and other inflammatory arthritis, such as rheumatoid arthritis. These are observational and not at a cause and effect level. I would like to talk about low quality research. Unfortunately, most clinical studies on dietary sodium are of low quality and they have unreliable results, and that creates controversy. Dietary recall surveys, food frequency questionnaires, spot urine samples with and without 24-hour urine estimating equations, and single 24-hour urine collections cannot accurately assess a long-term sodium intake in individuals, and especially in association with disease. Food recall surveys, food frequency questionnaires, single 24-hour urine samples have very high random error. That favors the null hypothesis that there is no effect of sodium on that. But urine samples are much worse. Not only do they have very high random error, they also have a high systematic error that causes false health outcome associations, for example, J curves. Only multiple, carefully collected, non-consecutive 24-hour urine samples can accurately categorize an individual's long-term sodium intake. It is notable that single carefully collected 24-hour urine samples are adequate to assess population impact intake, and that's because the random errors both high and low cancel each other out. So this is data that we're looking at to show the impact of low quality research. This is data from the TOHIP trial, which was assessed individual sodium intake with multiple non-consecutive 24-hour urines. One can see a linear association with death. This is marking 2,000 to 7,000 milligrams per day. See within that range, fairly high degree of confidence in linearity. Sharp contrast is the pure study. This is death. This is sodium in grams per day. So just multiply by 1,000 to get the equivalent here. So 2,000, 4,000, 6,000, etc. What you see is a J curve with increasing death as dietary sodium goes down below 3,000 milligrams per day, and then it goes up as one goes beyond, say, 5,000 milligrams per day. Note the sharp contrast right here at about 5 grams per day and right here at about 5 grams per day. So what we did was we took the data from the TOHIP trial and sodium data, and we ran it through the Kawasaki equation. What we showed was the Kawasaki equation causes the TOHIP data to J curve. So the Kawasaki equation results in inappropriate disease associations when it's used. So some take-home punchlines from my talk. One uses the World Health Organization. It indicates that using dietary sodium is one of the most effective mechanisms to improve population health. Cost savings in their analysis from middle-income countries was a return on investment of 18 to 1. South Korea examined their intervention and came up with a return on investment of $70 for every $1 invested. We haven't talked much about potassium, but it is important. One was to optimize dietary sodium and dietary potassium would prevent about half of hypertension in the world, or about 750 million fewer people with hypertension. No high-quality data to support the health and cardiovascular safety of adding any amounts of sodium to diets. We don't have data that range from 750 milligrams a day to 2,000 milligrams a day. But what we do have supports that it may not be safe. Sodium controversy links to low-quality research, flawed outcomes, and is, in my opinion, advocated by unethical scientists. Either do know better or should know better. The mechanism to reduce dietary sodium is puzzling to many and complex. It is simply adding less sodium to food processing, be it at home, restaurants, or manufacturers. I would like to thank you so much for inviting me to speak with you. Bye.
Um, Thank you, Dr. Campbell, for this recording. And I'm so sorry for the background noise that I have. I don't know if it was audible for all of you or not. But I think this puts everything in perspective about where we stand with respect to salt. And I would like to invite our panelists now. So our first panelist is Dr. Rajesh Badani. Uh, He's the Associate Director for Aditya Birla Memorial Hospital in Pune. He's a specialist in complex ablation or device implantations and complex coronary angioplasty. Been in radiology and a teacher since 10 years. He's also the recipient for the DP Basu Award in Chennai 2008. He's the past president for the Cardiology Society of India of Pune. He's got numerous publications and it's a pleasure working with him in the past few years. I think it's been a huge learning, and again a very strong advocate for dietary recommendations in cardiovascular management. We also have with us Professor Sui Mui Ching, again a very dear friend, and she's joining us from Malaysia. So thanks to you for joining us at this time, which is I know is pretty late. She's a professor of family medicine and a consultant. Clinical specialist at the University of Putra, Malaysia. Her research focuses on hypertension, stroke, gestational diabetes, addiction, and alternative medicine. She's got over 168 publications and has collaborated internationally and holds key roles in global health organizations such as International Society of Hypertension, with the Women in Hypertension Research Group. She's also part of our advisory panel for the IAPN India Hypertension and Nutrition Core Group. We also have with us Ms. Suparna Mukherjee, joining us from Bangalore, India. She's a PhD scholar and has numerous awards and over 16 years of experience in cardiology and nutrition. Uh, she's working in one of the leading cardiology hospitals of India, which is Narayan Rudalay, and she's also been part of a lot of studies where she's looked at focused on biomarkers and cardiovascular health. Again, a pleasure to have you here, Suparna. We also have with us Dr. Hind Baheri, who's joining us from Sudan. She is the council member within International Society of Hypertension. She's an associate professor of physiology, the director of Sudan National Program for Control and Prevention of Hypertension and CVDs, and also the ISH RAG Africa coordinator. We have with us finally Bijoya Bhattacharya, who's been a rock solid support for conducting these webinars. She's an assistant professor and HOD Department of Dietetics and Applied Nutrition, Amity University, Kolkata. Again, pursuing PhD in hypertension, and has a lot of impactful contributions in the form of research papers, her studies, as well as a lot of books that she's written on nutrition, and a recipient of multiple awards throughout her extensive career. Thank you all for being here today and for gracing the situation. I think since we are talking about salt, my first question is actually for Bijoya. As in, what are some, let's say, cultural and culinary strategies which can help in reduction of salt while we still keep the flavor intact?
First of all, thank you so much, Mansi, for your kind introduction, and I'm really indebted to IPN for making me a part of this event today. So very good question put that you have asked me regarding the strategies which can actually help us to minimize the salt intake, right? So the salt reduction is indeed a very critical public health priority these days, especially for managing hypertension. But as we know, like in Indian cooking, salt is not just a seasoning. Like we are not using salt as a seasoning, but yeah, it is deeply embedded in our culinary culture. Like we talk about the curries, then we make chutneys, we make pickles, and everywhere the salt is being used. So the main challenge is like how do we reduce salt, and that too without compromising on the taste and the cultural acceptability. Because if we really consider the food of the Western countries and the food of us, the Western countries ate more of the raw leafy vegetables slightly salted, but if they're in the salt, they're just using as a seasoning. But here we are cooking in salt. So obviously, and multiple items we are using. In abroad, we have seen that people they are eating one flesh and with that a lot of veggies. So it's a one pot meal. They are mainly into one pot meal. But in India, what we are doing, we are eating an elaborative meal wherein we are having rice or chapati. Sometimes even the dal preparation as well. People are using salt, and then rice is there. Maybe if they are using the jeera or the cumin tempered rice or some lemon rice, then also they are adding up the salt if they're not taking the plain rice. Or if they're even having the curd rice, then also they are adding up the salt. So then they are not just restricting to the rice, they are adding up dal. So that is the pulses are there, legumes, then vegetables, then fish, chicken, then chutney, pickles, so everything, and so many salt intake, I mean quantities, every like it is there in the entire meal. So let me now share some cultural and culinary strategies that can maybe that can work beautifully in the Indian context, which even I have been trying with my patients. Like, firstly, we need to know the like we should harness the power of spices and herbs, which I believe all the other panelists and the fellow dietitians will also agree. Because Indian cuisines, we already gives us a very wide array of, I mean, natural flavor enhancers. Like we talk about the cumin, we talk about coriander, turmeric, mustard seeds, fenugreek, black pepper, ginger, garlic, and so many others. So these impart certain strong aromas and complex flavors, which can easily reduce our reliance on the salt. Now, for instance, a simple vegetable preparation with cumin, ginger, and coriander leaves can I mean, like, it can actually enhance or it can enhance the taste even with 30 to 40% of the less of the salt. Now, sourness. Now, let us talk about the sourness, which can also act as a substitute of the saltiness. For example, the tangy elements. If we really see the South Indian cuisine, there they use rasam, curd. Curd, if we at all take, we don't need to put salt into it, right? So sourness can be a substitute for the saltiness, like the tangy elements can add brightness and can also reduce the perception of blandness. For example, lemon juice, tamarind, raw mango. In India, we use amchur powder. It's a raw mango powder. Okay, sometimes, and if that is being used in the cooking, we don't even realize that if at all the salt is missing in that particular food or not. Then tomatoes and vinegar, they are certain common in our regional cuisines. So squeeze of lemon on dal or buttermilk, or maybe like adding some amount of amchur to chana often makes people not even notice that if the salt is cut down or not. Now, talking about the cooking techniques to enhance the flavor, like there are several Indian traditional methods. We use tempering. In India, we call it as tadka. So we use tempering. So that is there. Then with the roasting of the spices, we call it as bhuna. So the roasting of the spices, they are going to amplify the flavor and the aroma. So when spices are roasted, their volatile oils that the spices that they are containing are getting released, and they're creating a depth of the taste that compensates for the reduced salt. Even the dry roasting of the dals, like the moong dal that we use, by doing the dry roasting as well, or the seeds before grinding them into chutneys, also gives a very rich flavor, and people thus do not notice that if at all the salt amount has been reduced or not. Then next, coming to the use of the various fresh herbs and the garnishes that we use, like the coriander leaves, mint, curry leaves, dill, then you basil, and not just for the garnish, I mean, there's layers of freshness and intensity. And adding fresh coriander on the top of the dal or mint or raita naturally enhances the flavor. And thus, it also has been found to be reducing the need for the added salt, leveraging the umami and the traditional ingredients that we all know. Like, we often forget that certain Indian staples are naturally umami rich, like tomatoes, sesame seeds, mushrooms, curd, buttermilk, and even small amount of the fermented foods. So these give a savory of the taste profile, which can actually, track the palate into sensing saltiness, even when actual sodium levels are way lesser. Now coming to the mindful approach of the condiments and the accomplishment, like the lot of hidden salt comes from pickles, which I said in the beginning of my session only, like pickles. Then we Indians, we are fond of eating papad, the roasted papad. The papad preparation itself contains a lot of ghee and lot of salt. That's a lot of clarified butter and lot of salt is being used. Even the sauces. So instead of eliminating them completely, we can prepare low salt version or maybe reduce the portion size of it. So, for example, serving a teaspoon of homemade pickle for flavor rather than a tablespoon still satisfy cultural habits. So, people, if taking sitting to eat the food, if they are taking a tablespoon or maybe half a small katori of achar, the pickle, instead of that, if they're even just taking a small amount, so that means I'm asking them to cut down the portion size of the salt intake. And then there is should be a gradual salt reduction and palate training. And one of the important cultural insight is like our taste buds that can adapt over a period of time. Uh, Another very strategic move that we can take, which I often suggest for my patients who are almost at the stage 3 hypertension, I tell them that instead of taking so many items, you go for one pot meal. Probably for Bengali, we say that, okay, you cook the chicken or a fish with a lot of vegetables. Then in that case, you don't have to eat vegetables separately. You don't have to eat fish or chicken separately. So because two separate items will be having two separate amount of salt. But if you're making one item, then only one. I mean, we are just adding salt once. And instead of eating salted rice item like fried rice, jeera rice, or the lemon rice, we can have a plain steamed rice, which will not be having the sodium. In the south, the way the Southeast Asia people they eat the normal plain steamed rice. Even in India, also we eat that. So to conclude, Indian cuisine already gives us a treasure trove of spices, herbs, souring agents, and cooking methods that allow us to reduce the salt without sacrificing the taste. So by layering the flavors like spicy, tangy, aromatic, umami, we can actually make food culturally acceptable, delicious, and heart healthy at the same time. So the message is reducing salt does not mean reducing taste. However, it means, I mean, like we need to rediscover the richness of our traditional Indian cuisine, cooking practices, and thus we can use it for a better health.
Thank you, Bijoya. I think that was very well explained, and you've sort of summed up the whole dietary perspective excellently. I think it's a similar challenge that Malaysia also faces, Dr. Ching. So, in your country, what are the unique cultural or dietary practices that have influenced the salt consumption, and uh, what kind of interventions do you feel have worked for your country? You'll have to unmute yourself.
Thank you, Nancy, for your kind introduction. Okay, for Malaysia, we know that Malaysia is famous with a multi-ethnic country in Asia. It's also is a food paradise country because we have a variety of food from different ethnicity. For example, Chinese usually they love to cook their food using oyster sauce, using this soya sauce, as well as tomato sauce. Whereas I think Indian, thanks to Bijoya, she mentioned that usually Indian food you love to eat together with a dal, and sometimes it also have a lot of hidden salt. Whereas Malay, even though they take this ulam as well as belacan, but you know that belacan also have a lot of hidden salt. That's why I think first challenges will be a high consumption of processed sauce and sediments. Then second challenge will be a lot of street food. And the street food is available easily, and then the price also affordable and is very delicious. However, we know that at the back of the delicious food is the high salt diet. And for example, I think we love to eat these fish crackers. I mean, keropok leko in Malay terms. And then all these are high salt diet. And then all the street food, I think in order you want to get the customer, that's why they try to make it delicious. And even though you will sometimes you eat at home, but there is extra soy sauce on the table, or you eat at the restaurant, there are also extra sauces on the table of the restaurant. So on top of the oyster sauce, some Malaysian love to add on extra salt in on top of the food that cooked by the restaurant. And one of the very famous dish in restaurant for Chinese is fried vegetables. It looks like very healthy vegetables, but we know that once you fry with oyster sauce, I don't think it's healthy anymore. So I think these are the challenges faced by Malaysian. And for your information, we also have a variety of instant noodles. Actually, according to one of the local study, you just finish one package of instant noodles, you already consume about 4.5 grams of sodium. And we know that according to WHO, we only allowed to have 5 grams of sodium. That's why the salt content in Malaysia is far exit from the WHO recommendation. According to one of our local study is about Malaysian generally consume about 7.9 grams of sodium. In terms of intervention, I think it's go back to the multifaceted intervention, whereby education, especially public health education, is very important, because most of the Malaysian, they have this same concept like Bijoya mentioned, the low salt diet is tasteless. That's why I think first we have to educate them. Low salt diet also can be very, delicious, as long as you have the recipe, okay? By using all the herbs. So I think the second thing we are trying to engage this TikTok influencer. The Ministry of Malaysia actually they created this 15 TikTok influencer, and currently we have about 5 million followers as well as 1 million views using this TikTok to reduce this salt intake. Especially they try to use these herbs instead of this soy sauce in their daily cooking. Then for the third one is we really encourage more these activities to be held during a World Salt Week, whereby we'll have a webinar, and then we have the competition, as well as recipe how to reduce the salt, which fit into the Malaysian cultural food. And we also make it compulsory to have this mandatory food labeling, especially food labeling and the salt labeling, and teach the people how to read the salt labeling as well. So by this year, we make it about 14 categories of food to have this compulsory salt labeling. And food reformulation is also another step that the government is going to take, because I think by doing it slowly, by reducing the salt by maybe 10%, especially in the bread, I hope that this will be, I think, to reduce the salt in our setting. But of course, engage the community such as My Wash. My Wash is another association like Wash in UK. They also promote this healthy eating by coming out the cooking recipe, as well as having this webinar at Asia level to encourage and look at the policy in a different country. Finally, I think engage a primary care physician, because managing hypertension is the bread and butter for the frontliner like primary care physician. So I think in the future we need to incorporate this salt assessment in part of our daily consultation. So I think then only we can try to reduce the salt based on our local cuisine slowly. Yeah, that's all.
I think that is wonderfully put, from clinical to the public health interventions that are needed, and I think they are common for across the board for all countries. Um, but that gets me to a question. I think that's a very basic question, which I'll address to Dr. Badani. Sir, what is the evidence and how strong is the evidence when we talk about sodium and hypertension? And I think Dr. PC has also raised the question about chloride being a part of the problem statement when we talk about hypertension. So if you could enlighten us.
Yeah, good evening. I think thank you all for inviting me. And I believe we are more into, clinical and interventional cardiology. But when it comes to hypertension, as a clinician, what I've realized, first, I think I'll just get you the challenges that why dietary interventions are not discussed or told to the patients more, because probably we don't have much time with the patient to talk to them about diet. Number two, our correlation, at least in India, I think all the states is the same challenge, that you should have a very strong correlation between a clinician and the dietitian. Very few hypertensive patients reach the dietitians to get a true consult, which is there, because from our end there are only two sentences: please take less sodium, less salt in diet. That is only one or two sentences. But I think Ching from Malaysia, as well as I think Bijoya also mentioned, and you guys, all dietetic people, we need to have a strong correlation association with the cardiologist, which as of today, cardiologist or physician or general practice. Second part is, most of the people are still unaware of the fact that high sodium is one of the primary culprits for high blood pressure. And I think one question which Dr. Vijay had already asked in the chat box was salt sensitivity. We all know that majority of our patients are salt sensitive individuals. The definition of salt sensitivity is that if I increase the salt intake, my blood pressure rises immediately. And if I reduce the salt intake to at least more than 20% or 30%, I definitely can reduce my blood pressure. The question the clinician doesn't understand today is that they are thinking that if I give them a diet or tell them low sodium in diet, will the patient come off antihypertensive medicine? So if the patient is going to require medicines, what can I do for the diet? Because it's a significant cultural challenge. A North Indian, a South Indian, an East and a West Indian will probably have a very different cultural thought processes which are there. Now, coming to the main question of evidence, when we are talking about, is salt a direct essential correlation with hypertension? And I think Dr. Campbell showed a very, very good slide of the TOMS, as well as, there is another trial, which is the TOHP trial, TOHP2 trial, in which the interesting aspect, when I had gone through, we realized that your impact of salt reduction is the maximum in the first 6 months. The BP reduction is maximum during that time, which is around 2.9 to 3 millimeter mercury. The moment it becomes 12 months, the pressure reduction becomes 2.5. And the moment it is 18 months, the pressure reduction becomes 2 millimeters. The question is, the adherence to the dietary regime becomes very difficult and sustainable over a period of time. I think one interesting and a very, very good paper which I came across was salt substitution for salt as for stroke reduction, which was probably done by the Kazuma Kari or the Hope Asia Network group people. And this was in the villages. They had randomized people to either salt substitute or regular salt for a period of 4.7 to 5 years, which was there. And in that time, they identified that with this sustained salt reduction, they found a stroke reduction relatively to be reduced by 19%, non-fatal MI by 12%, and cardiovascular mortality by 15%. So one thing is that this is the only paper which gives you a very direct correlation that salt reduction can have a direct impact on stroke, non-fatal MI, and cardiovascular mortality. So I think if we all have to design a strategy across the world, or at least in our country, we first need to come across that every clinician should believe that salt is a culprit in developing hypertension. If I reduce salt, there are chances of blood pressure coming down. And blood pressure coming down will directly be correlated to stroke, renal failure, myocardial infarction, heart failure, as well as, vision related ophthalmic issues. So I think how we can correlate in today's era is something that we need to come across. And that is where the salt calculator, people should know that I'm having more salt and more salt is going to be hazardous. And if I reduce salt, it will be beneficial. But if I do it only for 6 months, 1 year, it will have a transient benefit. And the moment I increase the salt, straight away my blood pressure will rise, which is there. So I think in a nutshell, I believe clinician should be very serious about the dietary aspects or the non-pharmacological impact of diet on hypertension. If the clinician is convinced, then I think the work becomes much easier. Here what is happening is dietitian is convinced 100%, clinician is convinced less 20 to 40%, and the patient is absolutely not convinced or less than 10%. So by the time it reaches the end point, your benefit is not there and the patient goes home. Rather, even after meeting us, he's going down and he's having a vada pav or a burger or a pizza before going home. So probably I think that is one thing in the mindset, that if we are all able to collaborate very well, from public health to the dietitian, to the clinician, to the government authorities, and even from the tax purposes, if I have a high salt containing substance, that should be taxed more, which I think Kerala has just started that particular thing about high salt intake and all. And I think we need to learn from you people, dietitians, that how to look at the food labels. How can I understand how high or how bad is the sodium in this particular product? And I should probably tell our patients very quickly in a minute that 10 products this you should preferentially avoid. So I think thanks for the question, and I think we can discuss or take it further later on. Thank you very much.
I think, sir, that's a very valid point, that it has to be a collaborative effort, and we can't all work in isolation if we are looking at reducing salt intake. But that gets me to a question, as in globally, uh, what are the successful public health policies? So I'd like to ask Dr. Norman Campbell if sir is still there. So what have been the successful public health campaigns till now, or regulations that have helped in salt reduction?
Thank you so much. I did mention that sodium reduction is very, very simple because natural foods have very little sodium. The intervention is simple. Humans are very complex, and that's the problem. So there are strategies, and the World Health Organization has something called SHAKE, which is sort of an overview of interventions to reduce dietary sodium. Resolve to Save Lives is an international organization that works with the WHO, and it has a sort of update off that with more interventions, and the WHO is updating their strategy. One of the first things to note is that each country is unique, and so India has recognized that, as many of the other speakers, in particular, the cultural significance of India actually forming as a country relating to salt. One of the critical things is examining the strengths, weaknesses, opportunities, and threats, or a SWOT analysis of to start. The next is to actually develop a national strategy based on the strengths, weaknesses, opportunities, and threats that are within India. One of the key things is to stimulate governments with an economic analysis. And again, there's very, very few interventions that can improve health and save a lot of money. And in middle-income countries such as India, the estimates are that $18 is returned to the economy for every dollar that's invested in reducing dietary sodium. But an economic analysis, often Indian intervention, would be important if it's not already done. Other speakers have indicated the importance of establishing baseline data, how much sodium is being ingested in India, and I've seen meta-analyses off that. What are the sources, the critical sources of sodium in the diet? And what's the variation in those products? And you'll see the same products, some from some company having very high levels and others being low, and that provides an opportunity to work with industry and others to reduce down to the lowest level. India is more complex because of nutrition transition, and one of the publications that really shocked me
was an examination of a small Indian rural community that had almost no hypertension in the community. And 30 years later was resurveyed, and 1 in 3 adults had hypertension, and that's related to nutrition transition. Really the industrial production of sodium from a very scarce, rare, expensive commodity to something that's very, very cheap and everyone's using. Education has been mentioned, particularly important for home. Low salt substitutes, very, very important. And also addressing the cost of them. They cost a little more than sodium chloride. And so intervening to make sure this low salt substitute is the same or lower cost would be important to the public. Out of home, well addressed through the SHAKE program, education, food reformulation. One of the best countries that I've seen is Argentina, where they told industry, you have 6 years to voluntarily reduce the amount of sodium to the target, then we're going to regulate it. And that provided the industry flexibility to prioritize their products in a voluntary sense for 6 years, but then the government regulated, and it was thou shalt not put more than this amount in. And it seemed to work well. An overarching healthy food strategy is very, very important. And these are things like not marketing unhealthy foods to children, healthy food procurement policies so that governments aren't buying unhealthy foods and providing them to people such as in hospitals and schools and other things. Warning labels on foods that are high in sodium, physical policies, and it was mentioned, and I was so happy to hear that one of the states of India was going to tax higher sodium foods. But those are the types of things that work well, with much more detail in those published strategies. Thank you so much.
Thank you, Dr. Campbell. I think that was wonderfully put. And yes, we need to take inspiration maybe from Argentina and look at having flexible regulations put in place. My question is to Dr. Hind now, and what is her perspective for Sudan, and are there any lessons that we can learn for what Sudan has done till now for salt management?
Thank you very much. First of all, I would like to thank you for giving this chance and for the AAPN Association. Really, Sudan has the second highest prevalence of hypertension, and it has been long since this has been established. Unfortunately, we have other risk factors of importance. Now we are having armed conflict, which still adds to the burden which is there. Last year, 2024, we had the screening program of the MMM, and we had astonishing results, which I may show to you. And it led us to raise the Sudan National Program for prevention and control of hypertension and cardiovascular diseases. High salt intake is one of the most risk factors in Sudan. Most of our food, it contains salt. And we are now establishing this program. We are having already an MOU with the Minister of Health to initiate the policies, the correct policies. We are still having this program going on, the screening program. We are going to transfer the high-risk populations, those who are of pre-hypertension and of hypertension, recognized newly or old cases, and then we will put them on a long cohort study so that we can try to improve or put initiatives for how to reduce salt. One of the important things in these surveys is, as Professor Norm already mentioned, it's very hard to measure salt intake, dietary salt intake, and especially if it is self-reported. We are depending up to now on the self-reported. It is not accompanied by biochemical tests in the urine. And so maybe if we squeeze ourselves in the high-risk group and the hypertensive group, we can put initiatives together with the international cooperation and interventions And we try to improve our community base through the media, to improve awareness and early detection, as well as to accompany the Ministry of Health to put the policies to reduce the food which contains high salt, like bread and other products. Thank you very much. I can give you a short screening survey. The last survey, 2024, the normotensive, the population was 85,000, out of which 64.6 were normotensive. The pre-hypertensive, 14.4%. Stage 1 hypertension, 14.3%. Stage 2, 3%, and stage 3, 2.7%. And with a very high percentage of newly discovered among all these categories. Thank you very much.
Thank you, Dr. Hind. I think that is a brilliant perspective because I think we all are probably heading towards that kind of a prevalence here as well, with newly diagnosed hypertensive burden being extremely high. I think to sort of get it all in line, my question is for Suparna. One, how can healthcare providers better communicate the risks of high salt intake? And are there any low cost practical interventions that have worked for you?
Thank you, Mansi, for this opportunity, and also thanks IAPN. Uh, I am exclusively working in a cardiac hospital, and I want to share my daily experience. If I'm seeing 10 patients, in that 10 patient, minimum 2 to 3 patients are pediatric. This is the first thing. And all of them, you can see 99% are obese and they have a hypertension. This is one thing always like make me worry. Second thing, I want to quote Dr. Ajra yesterday. She a nice quotation he given that population have to work together. So as a healthcare, we have to work. Yes, we have to percolate down whatever the informations we are having in a very simplest form, because patient, that can be pediatric population or adult population, they only understand very layman language. So first and foremost thing is required is they have to understand not only the salt, visible salt which we are adding in the food, but the invisible salt. There's a lot of hidden salt. Now it's a like common practice. We can see that any child is asking for anything outside food, mostly the chips or kurkure or the biscuits or bread, which is like ready to eat. So there is the one very big problem, because everybody want ready to eat food, and their direct salt, indirect salt, or as a preservative, salt is there. And that's one of the basic culprit. So when you're going to the pediatric populations, they have to carry minimum 1 to 2 box to their school. And the parents, they think that how much to cook. So minimum they depend on 1 ready to cook food. And that is one of the biggest source for our pediatric population to go with the extra salt than their requirements. So when we talked all that, yes, we are the person as a clinical dietitians to start to to aware the people. So first is our counseling. Second, next is coming that school have a very big responsibility. School have to take a responsibilities, because student can be the first salt satyagraha influencer. If we can teach them properly that which foods are high in salt, though like they should have like health education curriculum where unhealthy food, healthy food, there should be a board, there should be different type of activity. This is very important, because they are the main people in our complete community. Second thing, there should be always, if you see school level, workplace or community, everywhere we need more and more screening. Screening should not be only hospitalized based. The basic to check their hypertension, how much they're normal, like to 12 years boys onwards, like adolescents onwards, their blood pressure to be checked every year onwards, or maybe very often interval onwards. That's very, very important. Without that, how we can think about the awareness? So that's very important. Second thing is very important is, like when we are telling health education curriculum, that is coming with lot of engagement program. So there's a lot of, it can be school level engagement, it can be community level engagement, it can be workplace engagement, it can be hospital, whoever working for them engagement. But lot of engagement program is required, because as a human being, we need every time to somebody to remembering, like make us to understand whatever diet chart I'm giving to a patient, within a month they will forget. So their engagement programs are very, very important. And the last not the least, healthy environment promotions. So of course, we all know that it should come from our government level, but as a normal populations, people also, they should aware that why this cardiac arrest or heart disease are increasing, the first line heart disease, the cardiovascular disease. One of the main culprit is hypertension. If we are not addressing that one, and if we are not going to the root, that is our food daily, and our like 50% food, 50% exercise, both we are lacking. So we have to focus on both, and we have to come up with more and more awareness. So I think it's like it's a topic which can go on for another 2 hours. So shortly, I want to tell that clinical dietitians should be the first level influencer for the salt satyagraha. Then it should it should be going down to first to the students or the patient or to the health worker or the workplaces where we are going to give the talks. So that we should always remember. We can go for any other talk, but we should make sure that 1 or 2 slides should be there where we talk about salt, because we know how salt is a culprit. Thank you.
I think wonderfully said. We need to create that awareness. And I think one of the purpose of this webinar today is to create awareness on salt. And we have the Microlabs team with us today, Mr. Vignesh and Mr. Vimal Nair, who conceived the idea of a salt calculator and have been instrumental in getting it to a stage where we are today. So my question is for Mr. Vignesh. Why the need for a salt calculator? When we talk to people, I think the first response that they get is that their perception is that they do not consume excessive salt. So why the salt calculator? Over to you, Mr. Vignesh.
Yeah, thank you, Ms. Mansi. And also Dr. Rajesh Badani is also there. And our KOL who was there right from the first step which we took into this activity. See, the interesting aspect is we at Microlabs, I think 2 years back, we thought of taking up an initiative which is more into non-pharmacological therapy of hypertension management. So even though many risk factors are available to take it, from a corporate perspective, we found salt is the least spoken. I think Dr. Rajesh Badani always talks about this particular point because it is least spoken, but it creates a maximum impact. We have a team which caters to more than 25,000 doctors across the country. So, and we have a company where we are traditionally into cardiology therapy. We are a strong player in this therapy. So we wanted to have an awareness because these kind of awareness would happen only when a corporate joins hands with association like IAPN. I think Dr. Mansi, when she got involved into this, we had plenty of discussion with my colleague Vimal, who is also glued to this particular webinar. Why salt calculator is a very interesting question, because the perception for the people, unlike sugar, which has been taken up, is salt people don't given the importance because the salt is today calculated, is being used on the taste parameter, not on the scientifically measured quantity. So that got us to this point where that how do I use salt or how do I measure salt? So unlike European countries, I think this point was brought in because we had plenty of discussion with the IAPN team with Ms. Mansi. So what was the communication is, European society, the salt, the food habit is something like that where people take food outside. Whereas in a country like India, 80% of the time the people cook food and bring it to the office or wherever they go. So the salt which is being consumed can be titrated down at the home itself. And we wanted to create this, so the salt idea came in. So how it can be formed is another point of discussion. There were 21, I believe Ms. Mansi was giving, I think, gave us some 21 to 22 questions, which we wanted to take it up. But end of the day, when we take it through our marketing team, we found that there are some 7 to 8 mandatory questions which can be formed. From that, we would be able to identify how every individual on a daily basis is going to consume. So from 11 to 12 grams, which currently an Indian population takes, we are today working out towards the WHO goal of 5 grams. So that's how the salt calculator has initiated. And the IPEN team has already done it through their members, and the results have been very encouraging. Now, any of the success of this kind of initiative in a country like India with vast population with different set of food habit, it's scaling up this initiative. So there comes the private players role, someone like Microlabs with a social awareness initiatives. We brought in this salt calculator. Now the phase 2, once the tech in place, we are going to take it up to the next level where our full-fledged team is going to take it to the general public with the help of HCPs, study this entire initiative, how calculating salt usage on a daily basis on an individual from a family perspective, or how it can be taken up. So we are happy that our initiative, which coined 2 years back as I am on Sauce Satyagraha, had gone into a global stage, and definitely this has been made possible. I think the support what we have got from IPEN, I think is just a beginning. I think team would agree with me. We believe we are in right place and right track. On World Heart Day, with this kind of initiatives where a corporate is involved, I think we are really on track. And it is not there is something like commercial angle to that. Please believe us. This is something like which we want to support and give back to the society. I think Mansi, with the support of IPEN and the KOLs like Dr. Rajesh Badani and many more, we are on the track to reach the 2030 goal from WHO. I believe that's a right statement I can make. And thank you once again to the team members for giving us this opportunity.
Thank you, Mr. Vignesh. Indeed, it is one of the, I think, landmark initiatives that we have. For all the HCPs who are here, the salt calculator, the purpose is not for us to give you an exact calculation of how much sodium is a person consuming. The purpose is very simple, is to create an awareness. As Mr. Vignesh said, we've been already made aware of sugar, of oil. We have consciously started reducing the intake of sugar and oil to a great extent. The similar concept applies for salt as well. So once you use a salt calculator, you become aware of how much salt are you buying in a month, how many members are there. So on an average, what are you consuming? Now, this is just the added salt intake. We need to remember that there's so much of salt that we are consuming from processed foods and packaged foods as well, which actually adds on to the salt intake in our daily diet. Now, what happens is, even if the salt calculator tells you that you're within normal, and you're consuming outside food, you're eating outside, you're consuming, let's say, a lot of packaged foods, as Dr. Ching or I think Bijoya mentioned, one packet of the instant noodles, it completely wreaks havoc with the salt consumption that you're supposed to have. What we'll do is I'll run a short video of how the salt calculator works. It's a very simple steps that you need to follow, and we're happy to collaborate on that further. Thankfully, this video doesn't have an audio, so it wouldn't be that big a challenge, but we will upload Dr. Campbell's video separately, so for everyone to be able to view. And I really apologize that it was not as audible as it should have been. So this is the salt calculator, and So we just start with the doctor's name, the patient's name is optional, phone number is optional, mother tongue is mandatory because we want to track the ethnicity. We are looking at the city, how many people eat in your kitchen, number of children, and then you can add the ages. That answers your question, Dr. Archana, that you were asking. I'll come to that. And the amount of salt that you buy in a month, and the predominant or the primary salt that is purchased. How many times do you eat outside as a family? What is the blood pressure reading? Again, optional question for the person who's giving an answer. And what is the perception of a person who's answering? So this is what the results look like. It's a traffic signal, the typical traffic signal that method that we've tried to use here. The purpose is, like I said, extremely simple, that we are just wanting to uh, create an awareness, and in the bargain trying to trying to inculcate more behavioral changes, where, let's say, the government of India has come up with with sugar boards in all schools, but again, unfortunately, no one talks about salt. If you look at the recipes that are there, the online recipes which we probably rush to, uh, they all talk about how much sugar to be added, but when it comes to salt, they say, add it as per your taste. Now, hopefully that is something that we should change in the future. We are happy to talk to you about how the salt calculator works. Ultimately, what we are looking at is, maybe the first time that you ask someone, you may not get the correct answer. The person may not be aware of how much salt that they are buying. And trust me, that is one of the biggest challenges that we had. The first time you go and ask a person and they say, we are not really sure, we know the type of salt, we've shifted from, let's say, the regular salt to pink salt or Himalayan salt, but no, we don't really know how much are we buying in a month or how much are we consuming. So let's take that pledge to create an awareness. And I think there are a few questions. Dr. Badani has answered a lot of these questions for us. I'll just pick up a few questions that still are pending. So, yeah, Bijoy, I'm sorry, wanted to add something. I think Archana has asked this question previously in a webinar also, which is, what are the recommendations for salt in children? Vijay, would you like to answer that? So we have the RDAs. I think, Vijay, if you could help us with that. Not audible. Do you want me to go ahead? I think I'll just give a very quick overview.
Am I audible now?
Yes, yes.
Yes, yes.
Okay, so basically, the recommended daily sodium limits, we already have an RDA for it. So the recommended daily sodium, hello, am I audible?
Yes, you're audible.
Okay, okay. So the recommended daily sodium limits for children, it varies by age. I mean, with the younger children, obviously would be needing less. So approximately less than 1200 milligram for ages 1 to 3 and less than 1500 milligram for ages 4 to 8 and less than 1800 milligram for ages 9 to 13. However, for the teens, like who are in the age group of between 14 to 18, can aim for 2300 milligram or less. But here I would like to add up something, Mansi, that is, it is about the sodium that we are seeing, which are having a physical presence. I mean, we are using it separately. But there are so many foods which are having the sodium during the processing. Now, children, they're very much fond of eating the processed foods. And we cannot even calculate that how much sodium is there until and unless it has been given in the nutrition level. And in the nutrition level also, it is being mentioned that this much given per 100 gram. Correct. It is being mentioned. But how much exactly the child is eating? One point. Secondly, a child is going to school and sharing the tiffin. Maybe the parent is controlling the sodium at the home, but when the child is sharing the tiffin at the school, then also we don't know like how much the child is actually consumed directly from there. Another very interesting thing that me and Suparna one day we were discussing at length, that is in Bengal, especially the people are very much fond of eating muri. Although it's a rice-based product, but that also need lot of sodium during the cooking. And now, if I say about the rural Bengal, if the children over there do not have, even not just the rural Bengal, I mean the rural India as well. The children, they do not have the access of so much of processed foods or the ultra processed foods, but then they are consuming muri, the puffed rice. The processing itself requires so much of sodium. One question Archanaji asked in the chat box, like how to minimize the sodium content. Like one was the options that I said. Another thing is, as the children were very much fond of eating, especially the urban children, if I'm talking about, they're fond of eating pastas, noodles. So the rinsing helps to eliminate a lot of sodium that is there in the surface. Because that sodium has been used during the processing and that is being there in the surface of it. Okay, so by rinsing, it really helps. Then steaming, boiling, and throwing of the water. I agree, a lot of vitamins will get lost, but considering the sodium content of the food that is being added artificially from the outside during the processing, that is a big concern. So that will also get minimized. So it has been seen that boiling, steaming, and throwing of the water has also been found to be minimizing around 50% of the sodium from the foods. And for the pastas and noodles, if after boiling it, or if they can rinse it properly, then during the rinsing as well, the sodium is getting lost. So the choice
Thank,
of foods, the quantity there very important.
thank you, Vijaya. I think very well explained, and you've answered quite a few questions. I think I'll just ask for a few takeaways from Dr. Badani. If you, so if you could give us one takeaway from this whole session.
I think the takeaway that I feel is very, very relevant is number one, good collaboration between dietitian and the doctors. Number two is the patients probably are still not fearful that hypertension is a dangerous condition. So you should be able to have a couple of slides, like one of them which tells you that the cause of sudden cardiac death, the odds ratio of hypertension is 3.5 versus diabetes, which is just 2.6. People all over the world believe diabetes is more dangerous than hypertension. But still, this data tells you SCD with hypertension is very high. And secondly, a paper from the Hope Asia tells you that the correlation of coronary artery disease and stroke in Asians is much, much higher than in Caucasians. So whatever we are trying to do, we need to really get hypertension. And I think by statistics also, hypertension is the number one silent killer. So these are the 3, 4 things. If we are able to convince our patients that this disease needs medical therapy and non-medical therapy, and non-medical therapy, particularly diet, is an important essentiality. I think if that is being convinced and the patient and the family are involved into the therapeutic process as much passionate we are, maybe I think they will take over, and maybe that will spread to the community, and that will probably spread at national level. And maybe our country, maybe there is a high likelihood that we may reduce the prevalence or the incidence of hypertension and its subsequent complications. Thank you.
Thank you, Dr. Badani. I think that does really sum up. Dr. Ching, any comments from you to wrap up the session?
I think mainly for us to cut down the salt is we need to do it. By gradually. Most important thing is we need to implement the policy. Once the policy is there, I think we can do it better. Yeah, thank you.
Dr. Campbell, your parting words.
My final thoughts?
Your
Well,
final thoughts. Yes.
Well, I think you're very much on the right track. I think getting advocacy, education off the public, finding out how much salt people are perceiving that they take, and India is not unique. Everywhere in the world, people think they're eating healthy but aren't. But using this to try to stimulate government action and to develop a multi-sectoral task force that'll develop a strategy will ultimately be of a great assistance to India.
Thank you. Dr. Hind, any last parting words?
Yes, sure. First of all, that salt-dependent hypertension constitutes 50 to 60% of hypertension in Sudan and most probably in Africa as well. We need collaboration. It's not an easy work to do alone. We need collaboration, and we're very happy to have you in this, or for us to attend with you these sessions. And I really am looking forward for creating a working group to have proposals and to raise it, and we have joint proposals and implementation. Thank you.
Thank you so much. Suparna, last few words.
I think here the most of the fraternities and the attendees are nutritionists. So I think this message for all the nutritionist, dietitian, clinical dietitian from the nutrition world, we have to be more sincere with our patient and with our spreading awareness, and hopefully we will achieve the core thought behind this salt satyagraha to reduce the normal population salt intake. Thank you.
Thank you so much. I think we've had a wonderful session and we've heard a lot of key takeaways. Most of them may be focusing on how and what we can do better. So like Dr. Hind said, we do need to have a working group who are passionate about working in salt from different regions of the world, all coming together, and people and companies like Microlabs to support us in achieving this. So a very good night, a very good day to all of you. Thank you all for joining us today. It's an absolute pleasure. But before we sign off, we do have the Hypertension Times, the newsletter by the Hypertension Core Group that will be released and will be available for everyone to view in about 10 days. I think the effort taken by Alka from Itawa chapter of IAPN India has been incredible in making this a success, and it wouldn't have been possible without her perseverance to curate and get this all together. We look forward to having you again tomorrow for the session on pharmacological management of hypertension, which would be addressed by Dr. Badani and Dr. Sanjay Agarwal. Thank you again, and a very good day.
Thank you. Bye-bye.
Thank you.
Good night.
Thank you. Bye-bye.
Thank you, madam. Thank you, Mansi ma'am.
Thank you.